to see so many people here. Welcome. Okay, let's see. Okay, we always let people know if we have disclosures because we have some commercial interest and I don't. So because I'm starting, I thought I would just give some quick facts and figures about lung cancer. And it's important to recognize that lung cancer by itself is actually the third leading cause of death in the United States. It causes more pulmonary deaths, if you will, and I'm a lung doctor, than all of the other lung diseases combined. And I don't think people really appreciate that. Those numbers actually are starting to come down and we're really happy about that, but you can see how big a problem this is. And that is also true in the world. So in men and women in the United States, it's the number 3 cause of death. And in the world, this map is for men on top and women on the bottom. And a country that's colored blue, lung cancer is the leading cause of cancer death. Pink is breast cancer. And what you can see is for men, there's no question that lung cancer is the leading cause of death in men around the world. It is probably, though, going to be true of women very soon. So breast cancer mortality has been falling for a long time. Lung cancer mortality in women around the world is actually going up, even though it's coming down in the US. And that relates to a lot of things like cigarettes, environmental exposures, and so forth. But in the world last year, 1.8 million deaths from lung cancer. So it's an enormous problem, and that is why we need all the scientific and clinical work that's going into making people survive better and be cured. So Dan mentioned that we started the thoracic oncology program at Yale Cancer Center back in the early 2000s. 2003, 2004 is actually when we first started seeing our first patients. And this was really an idea that several of us had that was born out of this realization that for our patients who either knew they had lung cancer or we were concerned they had lung cancer, at this time when they were emotionally, psychologically, physically challenged, they had to run around and see all these different doctors because lung cancer inherently is a disease where you need to see lots of different people to get the proper treatment. And so our patients were running up and down these spokes, doing the best they could to get the care that they needed. And a few of us got together and said, you know what, we should really join this into a wheel that turns around the patient. And patient-centered care now is something we always talk about, but this was patient-centered care back in the day before that term had been coined. And this really was the concept behind our thoracic oncology program. And so here's that patient, same people around the circle, but now connected in many ways to the care that didn't exist before. And we've been doing this arms around the patient, patient-centered care really since we started this program, 2003, 2004. And so there's a whole group of people that support the patient. You in the audience who are our patients know who your nurses and the nurse coordinators are. We have this great administrative staff that holds it all together. There's one phone number that you can get to for everybody. That number is 200-LUNG. When I called that number back in 2002 and I said, who's got this number? It was in labor and delivery. And I said, you don't need this number. I need it. And so, and then we all meet once a week formally in tumor board. Everybody's sitting there and we freely talk about patients. It's a really good experience for us. We learn, we teach, we get other opinions from other experts, and our patients benefit because they get many expert opinions for their cases, whether they're complicated or uncomplicated. And then lung cancer screening is part of this program. And if you will, it's the before. We hope that most of the patients we screened don't have lung cancer. If they do, what we're trying to do is find them early. And so lung cancer screening as an entity has really come into its own in the last just few years. And I hope that after the next few minutes of my talking, you'll agree that this is a really important thing to be getting done for people who are at risk. And so why do we screen for cancers? And that has a very simple answer that if you diagnose a cancer early, before people have symptoms, chances are it won't have spread, and we have a much better chance of achieving a cure and saving lives. And so if we look at breast cancer, and cancers are staged 1, 2, 3, 4, with 1 being early and 4 being advanced, this big blue area is half of breast cancer patients who are diagnosed early, and that is because over the last number of decades, screening mammography has really just become part of what we do. People expect to have their screening mammograms. It's just part of now normal medical care. It wasn't like that, 40 years ago, but it is now. And if you look at this green chunk here, these are people diagnosed with the next stage 2. And this 80% of women who are diagnosed with breast cancer are being diagnosed at early stage, largely because of screening. And their chance of living long or being cured is really good. We're not in that situation with lung cancer because we haven't been screening for very long. So this big purple piece are people who are diagnosed with advanced stage. And relatively few people are diagnosed early, and predominantly these kinds of people were discovered in the past by accident. So if you happen to have a chest x-ray because you were going to have a knee surgery, or I was talking to somebody in the audience and her dad was diagnosed because he fell off a ladder and he ended up in the ED and had a CT scan done. So that we weren't doing anything in the past to actively find these people with lung cancer at early stage. And obviously we want to look like this or even better, and we need to start screening. We need to screen for lung cancer and find these people early. So I thought the easiest way to go about this was just to do a little bit of frequently asked questions. So what is the screening test? Who should be screened? And then I did want to touch on decision support for lung cancer screening. This is the discussion you should have if you are going to be screened with your physician or with us in the screening program about the benefits and the potential downsides of screening, what your risk is, and so forth. Is there proof that lung cancer screening saves lives? That answer is yes. Are there downsides to getting screened? Yes, there are some. It doesn't mean you'll experience them, but you need to know about them. And then we can tell you ballpark what your personal risk for lung cancer is. So the screening test for lung cancer is a chest CT scan that's done with low dose radiation. And when we say low dose, for a low dose chest CT that's done for purposes of screening, that's about double the amount of radiation you get in a year of ambient radiation from your environment and the sun. And what we get with a CT scan is this really beautiful picture of the lungs. And when I talk to patients, I say, okay, the CT scanner makes like you're a loaf of bread. And we're sending your loaf of bread through the scanner and it's slicing you. And we're gonna look at the slices and see whether we see spots or dots or anything abnormal that might make us concerned about anything. This is the heart, and the only thing I can say about the heart on a CT scan usually is it's there and the size is okay. And these big areas are the lungs, and all these little squiggles and dots are normal blood vessels and other structures of the lung. So this looks great. This was a screening scan done in 2016. This patient continued to come for her annual scans, and in 2019, she had this spot here, which we call a nodule, which was a lung cancer. And so because she was being screened, she was found early, could have surgery, could be cured essentially. But it was because we were monitoring her in this way over the past few years in a way that we hadn't done previously. So who should be screened? The United States Preventative Services Task Force, which is the body that informs the Centers for Medicare Services on screening evaluations in the United States, says that people who are 55 to 80 who have smoked at least 30 pack years of cigarettes and are currently smoking or quit within the past 15 years are the high-risk population who should get screened. There are about 9 million people in the United States who meet those criteria. Right now, we're screening about 4% of that 9 million, and we really want that number to go up. And some people ask, what does 30 pack years mean? If you smoke a pack a year for 30 years, that's 30 pack years. If you smoked more intensively than that, it's going to take you fewer years to get to that 30 pack years. This is the workflow for our screening program, and I'm putting this up mostly to acknowledge Polly Sather, who's sitting in the audience right there. Polly, yeah. who really runs our screening program and does an amazing job of this. And so what we do here is people's primary care, physicians, providers, APRNs, whoever they're seeing in the community can refer in for this screen. And when they arrive, they meet Polly, who does a decision support visit. And this is a visit to discuss, I'm going to have this scan. Should I have it? What are the upsides? What are the downsides? What is my risk? And this visit takes about 20 minutes, and Polly actually does an individualized risk with every patient who comes through for the screening. They go in and they have their CT scan, they go home, the results go pretty immediately to the primary care person who ordered the study, and then you get the results. Because the screening program at Yale is embedded in the thoracic oncology program, if you need more, if you have a nodule and you need to be evaluated, you can come see pulmonary thoracic surgery. If you have a cancer, then the whole thoracic oncology program is really there to help you. So the proof that lung cancer screening saves lives is coming from two big studies. The first was done in the United States and was called the National Lung Screening Trial and had over 50,000 people who participated in this. They met that age and smoking criteria that the US PSTF later adopted. And the Nelson screening trial, which just finished in Belgium, had about 16,000 participants. And the Nelson trial still has not published its final results, but they've released the big results. And both of these studies showed that when you do screening with low dose CT, you diagnose more lung cancers than you would if you didn't screen or if you just did chest x-rays. The majority of these cancers are early stage, so you achieve early detection. If you find really early stage lung cancers, people's survival is terrific, more than 90% at this kind of magical 5 or 10 years, which is where we tend to say you're cured. If you make it to 5 years, you're cured. It turns out more people quit smoking if they participated in these studies. And interestingly, and this is an interest of mine, women seem to benefit even more than men. And there's a lot of concern that maybe women are more susceptible to the carcinogenic effects of tobacco than men. And some of these data are supporting that. And the bottom line was that there were fewer lung cancer deaths in the groups that were screened with low-dose CT in their comparative groups. And that is the gold standard for screening. You need to save lives. And so both of these studies have showed that. So, you know, that's the benefit. If you get your cancer diagnosed early, you have so much better chance of having it cured with surgery, radiation, techniques for treating early stage cancer. There are some downsides to having this kind of scan, though. These are mostly the other things that you see when you get these amazing pictures of the chest. The first thing is that lots of people have these little spots called nodules. Smokers have more. And if I sent 100 people who smoked 30 pack years through a scanner, 25 to 50% of them are going to have little spots, one or more. And it's my job really to look at that and say, we're not worried about this one, we're worried about this one. And they're very standardized readings now for these low dose CT scans to minimize all these false positive findings. The findings that are there but shouldn't be worried about, shouldn't be further evaluated, should not cause anybody to have distress. And the other thing is, as opposed to a mammogram that looks just at the breast, or colonoscopy that just looks at the colon, or PSA that is only measuring prostate antigen, a chest CT scan looks at everything from the base of the neck to the top of the belly and all of the organs therein. And we see lots of things that are like not important, things like cysts, little spots, you know, a slightly anomalous, meaning slightly weird blood vessel that doesn't really mean anything, but looks scary if you see it on the report. And so the interpretation of these things is really important. And that's part of the reason that we read here these scans in a very structured way. And once in a while, we'll find things that are clinically significant in those other organs. Like somebody may have an aneurysm of the aorta they didn't know about. And so that is not why we're doing this scan, but because we're visualizing everything else, we will see these things that then we can act on, you know, alert the primary care provider and make sure that that gets taken care of. Polly does this individual risk assessment for lung cancer. There are now a number of these calculators that include different factors about individual people beyond how old are you and how much did you smoke. So things like education, do you have other lung disease like emphysema? Do you have a family history of lung cancer? All of those are factors, and I listed here, and this list is much longer than this, things that we know can increase people's risk for lung cancer, although not all of them are quantifiable. But using this kind of calculator, what Polly does is do a risk of lung cancer over the next 6 years with every patient. Sometimes the risk is really, 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 really low. So it's a reasonable discussion to say, well, do you really need to have this CT scan? If it's really, 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 really high, we're going to push. You really should go and have this done. But I think it helps people to understand, you know, what the magnitude of the risk is in terms of going forward with the screening. And so to summarize, screening allows detection of early cancers with better chance for cure. You should talk to your primary care provider about whether you should have screening done. If you know people who you think should get screened, tell them to go talk to their doctors. You know, a friendly nudge in the right direction is often more meaningful than all the literature in the world. And a discussion with your doctor or with us will help you understand, you know, your specific potential benefit and maybe risks of undergoing the screening. It takes a village to do all of these things. And so we have a pretty big group here who is participating in the lung cancer screening program back in 2014, before Medicare had approved payment for doing the screening, that they would pay for it if it were done. We did a bunch of free clinics, and these were all the people who participated then. And I'll take questions.
Doctor, I would think one of the hurdles is insurance companies agreeing to pay for a preventive scan. There's no diagnosis. So is there any sense of headway, progress, someone making
so
that more amenable?
When the United States Preventive Services Task Force recommends screening, which it did for lung cancer back in the last day of 2013, December 31st, actually, Medicare should pay for it. Okay, so that Medicare now will pay for screening if you meet the criteria that it has stated. Okay, Medicare actually, this is a small technicality, approves to age 77 as opposed to the 80 that USPSTF recommended, but they will pay for screening. The private carriers like Aetna, Blue Cross, Oxford, all those people follow those recommendations. They often, the private carriers will screen beyond, they may screen beyond those much stricter criteria, so that if you didn't fall in those, in that group, it's still, and you have different insurance in Medicare, it's still worth checking. But screening for lung cancer is covered if you're a Medicare recipient, and that generally drives the other insurers. Okay, thanks.